professor in the Department of Pediatrics, and in continuation of your respiratory module, today we will, yesterday you, Dr. Noor discussed with you people upper respiratory tract infection, and today we'll discuss lower respiratory tract infection. So I can see only 86, 87 students till now. The later will be joining soon. Okay. So, chalo. Before starting the lecture, what do you people know about pneumonia? Anyone? Any student out of those 90? What
Ma'am,
is
they
meant
will
by
answer
pneumonia?
on chat, their chat
Whatever
will...
they like, whatever they like. अगर वो mic पे बताना चाह रहे हैं तो it's fine.
Okay.
हम 5 minutes का session कर लेते हैं. Anyone, any student? अच्छा, I can see someone writing. Infection of the lung parenchyma, fluid filled in the lungs. Okay, what else? What is pneumonia? Anyone else? Any infection or inflammation of the lungs. ठीक है, what else? How do you know that there is infection of the lung parenchyma or there is inflammation of the lung parenchyma? How would you know? When would you suspect pneumonia in a patient, especially in a peds? आज क्योंकि peds का lecture है. So how do you suspect pneumonia in a pediatric patient? कैसे सोचेंगे कि this child may have pneumonia? Patient तो आगे नहीं बताएगा ना कि we are having consolidation or infection of lung parenchyma or inflammation of the lung parenchyma. How would the patient present to you? Due to cough and sputum, tachypnea, tachycardia, ठीक है, or what else? Fever, chills, ठीक है, what else? High fever. Every high fever, Amna? Dullness to percussion, okay. What else? Somebody said tachypnea and tachycardia. So what is tachypnea and tachycardia in a pediatric age group? Who will tell me? When would you say that this child is tachypnic or tachycardic? Nobody? What is tachypnea and tachycardia in a pediatric age group? High respiratory rate. क्या बेटा कितना high respiratory rate शुजा? When do you say it's high for a child? Sputum production, high fever, consolidation on X-ray, cough. ठीक है. But what is high? My question is, what is greater than 30? Okay. Somebody said respiratory rate greater than 30 is tachypnea. So is it okay? Greater than 30? Age to age vary करता है respiratory rate. Very good, Sidra. But कितना? For which age? Greater than 60. Okay. Tachypnea is breath count greater than 40 in child above age 5. ठीक है. What else? Tachycardia more than 160 per minute. For everyone? Asim? For everyone? You said tachycardia is more than 160 per minute. Chalo, okay. Thank you so much for your response. Now we'll discuss and then we'll take questions later on. So this shows the basic purpose of asking you people before starting the presentation, since we are sitting in front of a screen and we don't know how many of you are sleeping and how many of you are actually present there at the other end. So just to have an idea, okay, whether or not it's an interactive session or are we just just speaking in front of the screens. So this shows that some of you, not all, at least some of you are awake. So, and the other thing that this shows is, okay, you people have at least some idea about what we are gonna discuss, at least some idea. So, as most of you said rightly, basically pneumonia is defined as inflammation of the parenchyma of the lungs. Okay? Pneumonia, the respiratory tract is basically divided into two parts: upper respiratory tract and lower respiratory tract. The respiratory tract above the vocal cords or up to the vocal cords is included in upper respiratory tract. Well, below the vocal cords, it's lower respiratory tract. ठीक है, जिसमें आपके मेन ब्रोंकस, राइट एंड लेफ्ट मेन ब्रोंकस आ जाता है, देन ब्रोंक्यूल्स एंड देन ऑब्वियसली द लंग पेरेन्काइमा. सो pneumonia is basically defined as inflammation of the parenchyma of the lungs. So this, why are we discussing pneumonia? Because it's a substantial cause of morbidity and mortality in childhood, particularly under 5 years of age throughout the world. And its single most important rival is diarrhea as a cause of death in developing countries. Here in our country, the two, if you are asked about the two more important, the two most common causes of pediatric morbidity and mortality, so that is pneumonia and diarrhea. So their incidence varies according to the season. Like in this summer season, the cause of death and the cause of illness due to diarrhea is more as compared to pneumonia, whereas in autumns and in winters, pneumonia is the leading cause of death and morbidity and mortality in pediatric age group. So pneumonia is estimated to cause approximately 4 million deaths among children worldwide. So this is an important thing to know. We should be able to pick up this abnormality earlier on, and we should be able to treat it. Now, something about the etiological agents. We basically divide it by according to the age of the patient. Since we all know, okay, there are different organisms which and the patient at different ages is susceptible to different organisms. For a neonate under 1 month of age, group B streptococcus and E. coli and other gram-negative bacilli, they are among the more common cause of etiological agents. Although others can also infect cause pneumonia, like streptococcus pneumoniae, H. influenzae. In previous days, before the vaccination era, when we were not vaccinating regularly, the H. influenza was supposed to be the most common etiological agent in all the age groups. But since the introduction of the widespread immunization, the incidence of H. influenza pneumonia is on a decreasing pattern. So now the other organisms are at high. Like we don't have any vaccine for a neonate group B streptococcus, for E. coli and other gram-negative. So they are the more common causes of pneumonia in a neonatal age group, along with the streptococcus pneumonia. Then after the neonatal age, in the infantile age, usually 1 to 3 months and 3 months to 12 months, the organisms are the same. Okay? The viral causes predominate, are the predominant cause of pneumonia in this age group, in which the respiratory syncytial virus and other respiratory viruses, parainfluenza viruses, influenza viruses, and adenoviruses. Well, according to now, since this presentation was made before this pandemic, so now the one of the other emerging cause is coronavirus also. So later on, maybe in your 4th years, you will be studying coronavirus as one of the emerging cause of pneumonia in all age groups. So till now, respiratory for infantile age group virus, and among those virus, respiratory syncytial virus, parainfluenza virus, influenza viruses, and adenoviruses are the most predominantly important causes of pneumonia. And among the bacterial, again, streptococcus pneumoniae and H. influenza. Others are less common, like chlamydia, mycoplasma. They can cause pneumonia, but if you are asked the most common cause, so so it is the viral pneumonias, and along with that, in bacterial, we have Streptococcus pneumoniae and H. influenzae. 3 to 12 months, again the same thing. All the respiratory syncytial virus again are the most important causes. Well, in 2 to 5 years of phase, again, it can be due to bacterial as well as viral causes. Among the viral causes, the same respiratory viruses, parainfluenza, influenza, adenovirus, and among the bacterial, Streptococcus pneumoniae, and sometimes H. influenzae if the child is unvaccinated, if the child is not taking vaccinations. So in that, second, somebody. Please speak a bit louder. Okay, you can't hear me. Okay, I'll try to speak louder. So in 2 to 5 years of age, respiratory viruses are the most common cause of viruses. And in bacterial, again, it's the same, Streptococcus pneumoniae. In the above 5 years of age, the most common cause of pneumonia is the community-acquired pneumonia. That is Mycoplasma pneumonia is the most common cause of bacterial pneumonia in that age group, along with the Streptococcus pneumonia, H. influenza, and again the viral causes comes at the second stage in this. So in an older children of 5 to 18 years of age, and more in adolescents also, the most common etiological agent is Mycoplasma pneumonia, which is also called community-acquired pneumonia. And along with that, Streptococcus pneumoniae, despite of the widespread vaccination, it is considered, it is still one of the cause of pneumonia in all the age groups. As I said, the incidence of H. influenza pneumonia is on a decreasing pattern. And among the viruses, influenza virus, adenoviruses, they all are considered as the important cause of viral pneumonias. Basically, the main purpose of all this etiology classification is to have a crude idea of what could be the etiological agent in different age groups. There is still a possibility that our 2-year-old is suffering from Streptococcus pneumoniae or H. influenza if the child is not vaccinated, or there are high chances of an adolescent child to be suffering from Staph aureus pneumonia. So basically, this classification is not the fixed one. This is just to have a crude idea so that it will aid us in starting an empirical antibiotic therapy. Achha ji. Now, something about the pathogenesis. What is the pathological events that leads to this inflammation of the lung parenchyma? So usually, as we all know, that the lower respiratory tract is normally kept sterile. And what are the reasons to keeping it sterile? First of all, all the defensive mechanisms. There are so many defensive mechanisms in the body. One is the mucociliary clearance. We have cilia in our nasal epithelium. It is there in the pharynx. So any organism is stopped there. Okay. Then we have some normal secretions in our respiratory tract that contain secretory immunoglobulins. And these immunoglobulins A, they are protective. And if by chance any organism goes in there into the lungs, so these immunoglobulins, they tackle it and they destroy it. And and then again, we have a cough mechanism. So whenever we cough, we try to expel out all the inhaled organisms or allergens. And again, there are certain macrophages that are present in the alveoli. Like if by chance some of the organism reaches down there to the alveoli and bronchioles, so there the macrophages and all the secretory IgAs and all the immunoglobulins, they fight against it and they limit the spread of infection. So naturally, normal human body, if otherwise is stable, otherwise healthy, that person has so many of the defensive mechanism. And this is the reason that despite of being so many organisms present in the environment, not everybody suffers from pneumonia. It is basically the weakening of the immune mechanism that causes spread of the infections. So different organisms involve the lungs in different forms. Like Streptococcus pneumoniae, what does it do? It produces local edema, and which aids local edema within the bronchioles, and that aids in the proliferation of organisms, and they're spread into the adjacent portion of the lungs. And this is the reason which causes, like Streptococcus pneumoniae, usually it causes focal lobar involvement. So once first it produces local edema, and which acts as a medium for the proliferation of organisms, and which spreads into the adjacent lung parenchyma, resulting in focal lobar involvement. And what does group A Streptococcus does? It usually causes more diffuse infection with interstitial pneumonia. Like, it does not cause a lobar form of pneumonia as in Streptococcus pneumonia, but it involves usually generalized form of pneumonia, interstitial pneumonitis it causes. And it causes necrosis of the tracheobronchial mucosa, large amount of exudates, large edema, and sometimes local hemorrhage. And it can infect the lymphatic vessels as well, which increases the likelihood of pleural involvement. Slides are not moving. Which slides are you people at? Currently, it is Streptococcus. Can you people see this slide of Streptococcus pneumonia?
No, मैम आपका स्लाइड शेयर रुक गया, आप दोबारा शेयर करें.
अच्छा जी, चलें दोबारा शेयर करती हूँ. अब is it moving now? कहाँ पे रुका?
Yes ma'am.
Pathogenesis. Can you see the pathogenesis? यहाँ पे ये सब देखा था, ये वाला देखा था pathogenesis that we just discussed. Any student can comment on this. कहाँ पे रुका बच्चे? No, सारे no कह रहे हैं. Is it still not moving? Which slide you people can see? Pathogenesis पे रुका हुआ है. क्या करूँ मॉडरेटर साहब?
मैम ये etiologic agent group by age of the patient, ये वाली स्लाइड है.
ये वाली स्लाइड आ रही है ना, तो बच्चे क्यों कह रहे हैं कि वो नहीं आ रही? मैंने यही वाली लगाई हुई.
लास्ट जहाँ पे रुका था उसके लिए.
अच्छा ठीक है. ओके नाउ इट्स मूविंग ना. चलो, तो पैथोजेनेसिस तक देखा था आप बच्चों ने ना, तो चलो आगे बढ़ते हैं. पैथोजेनेसिस से वी हैव डन द एटियोलॉजिकल एजेंट्स, so this is the pathogenesis. So everything about the pathogenesis is clear. It's fine now. Okay, चलो आगे बढ़ते हैं. So this slide you are seeing, this one is for the first time, Streptococcus pneumoniae. Basically, we were discussing the different organisms infect the lung in different ways. Like Streptococcus pneumoniae, what does it cause? It produces local edema, which helps in the proliferation of organisms, and it's spread into the adjacent portion of the lungs. So Streptococcus pneumoniae typically shows in chest X-ray in the form of focal lobar pneumonia. Lobar pneumonia. So lobar pneumonia कैसा होता है कि only one of the lobe is involved. I think we have one slide later on, so I'll show you people. Then Streptococcus A, group A Streptococcus, how does it infect the lungs? Usually what it causes more diffuse infection with interstitial pneumonia. Like, you will see both the lung feeds to be involved, and there will not be a specific lobar involvement pattern. And due to the exaggerated spread, the patient is at increased risk of developing pleural involvement or pleural effusion. What does Streptococcus aureus do? It usually manifests as bronchopneumonia. Bronchopneumonia, again involving both of the lungs. Sometimes can be unilateral. And again, it causes diffuse involvement of the lung, and it can extend to the adjacent areas. So the Staph aureus has the tendency to disseminate and causes sometimes it can also cause pneumatoceles. Sometimes it can produce the cavitation. Sometimes it can produce the empyema. Empyema is the presence of pus in the pleural cavity, or at times bronchopulmonary fistula, because it it is very difficult to limit the spread of Staph aureus. Virus, all the viruses, they infect the lungs in a different way. What they do, they directly, they usually result from a spread of infection along the airways. They attack the airways, sometimes the smaller airways, by the direct injury of the respiratory epithelium. Respiratory epithelium को उन्होंने involve किया, which result in airway obstruction from swelling and abnormal secretions and sometimes cellular debris of all these smaller airways. So what happens, like, this is the airway, the virus is going in here, it's directly, it does not go to the lung parenchyma, it attacks the small airway epithelium. Okay, when the epithelium is destroyed, there would be increased secretions, there will be mechanical obstruction, there would be swelling of the cells and cellular debris. So what happens, the smaller airways, they were already small, they swell up and the lumen smalls further. So this is the reason. Here is the picture. This is the normal alveoli, okay, and this is with the pneumonia. Okay, the cellular debris is involving the smaller alveoli. So what happens? This thing causes in smaller children, as we all know, बच्चों में हमने पढ़ा था ना, the etiological agents mostly they are suffering from viral pneumonias. Why? Because they already have a smaller epithelium, the smaller airways, and if there is mechanical obstruction of those smaller airways, that will cause obviously the more problem as compared to the adults. So this is the most common reason कि viral pneumonia, and this is also the reason for wheezing as predominant complaint, presenting complaint in pediatric age group. Usually we'll see so many of the pediatric patients coming to us with wheezing, and when we look for the cause, it comes out as viral pneumonias. No slide. Yes, I know there is no slide. अब आ जाएगी बच्चे. Can you see it? चलो. Diagnosis. How would we diagnose it? पहले तो ये बताओ. Now you people tell me. अभी तो हमने etiology कर ली सारी, और हमने कर लिया. नहीं, we have still time ना. We have till 10:30. ठीक है. So we have done the etiological agents and we have done the pathogenesis. अब how will we diagnose? कौन बताएगा? If someone wants to tell through the mic, you are welcome to tell, because others would be able to listen to you as well. Chest X-ray, direct मरीज आते के साथ X-ray के लिए भेज दोगे? Sputum stain, blood culture, chest X-ray, dry cough, dyspnea, ठीक है, or history, crackles on the basis of clinical representation in chest X-ray and clinical examination, ठीक है, or क्या clinical exam? What would you like to see in clinical examination? चलो देखो, we'll start with the history. ठीक है, tell me what points would you ask in the history? What could be the points in history? Breathing way. What is breathing way? What points would you specifically ask in the history? My question is this. Vaccination, very good. ठीक है. Presenting complaints में क्या बच्चे क्या पूछोगे वसीम? Fever, ठीक है. For how long it's there? ठीक है. Any viral infection that occurred? How would the patient know that they are having the viral infection? वो बता के होता है क्या कि I'm having viral infection? Cough productive or not? ठीक है. This is a very, very common presenting complaint, the cough. So who will tell me कि what is the age at which the patient can produce sputum? Is there any age? Is there any relationship of the age with sputum, or everyone can produce sputum? Cough with sputum is one of the, yes, you people are right. Cough with sputum is one of the main common presenting complaint of pneumonia. But the problem is there, or my question is, okay, at what age a patient can produce sputum? Usually in adults, what we do, you ask for the cough and you ask whether this child has a dry cough or a productive cough, and then you decide okay, if it's a dry cough, go to the cardiac ward or go to someone else. This is not a problem of pulmonologist. This cannot be pneumonia. So can we do this in pediatric age group? Like if a mother is bringing a, let's say, 2 years old child, and mother is saying that the child is having fever for 5 days and cough for 2 days. When you ask that is the child able to produce a sputum or not, and the mother says no, the child is not able to produce a sputum. So what does that mean? Does that child have pneumonia or not? Infant mostly have dry cough. No child in pneumonia mostly have dry cough. Yes, very good. और किसने बताया है ये? Usama. He could have. This is very difficult to say just merely on the absence of sputum. So ideally, before 6, the children cannot produce sputum. ठीक है, तो आधी तो हमारी पीडियाट्रिक एज और हाई रिस्क एज जो थी फॉर निमोनिया की हाई मॉर्बिडिटी मोर्टेलिटी की थी, वो तो गुजर ही गई. सो वी कैन नॉट रिलाई ऑन द प्रोडक्शन और द एब्सेंस ऑफ स्प्यूटम. अंडर 6 year of age, the child cannot produce sputum, or under 4 strictly, to be very strict, under 4 they cannot produce sputum. Between 4 to 6, because producing sputum is a coordinated effect, we have to move the secretions against the normal gravity. So that's a coordinated effort. So if the child is intelligent enough to produce sputum, between 4 to 6 can produce, but under 4 years definitely they cannot produce sputum. Rather, sometimes what happens, they cough and they cough, and then they vomit. When they vomit, it's an involuntary process ना, उसमें भी antiperistaltic wave होती है, तो उसमें थोड़ा बहुत sputum आ जाता है. But yes, the smaller children cannot produce sputum. Not only the infants, छोटे बच्चे under 4 years of age, they cannot produce sputum. तो production of the sputum तो ruled out. अब हम देखते हैं कि क्या करें. How do we know? First of all, history में there would be history of high grade fever, there would be history of cough, there would be history, if it's a very small children, sometimes they do present with subtle signs and symptoms like reluctance to feed, not able to feed, getting breathless on feeding. Let's see what's written in here. Yes, and very small children can also present with grunting. Grunting क्या होती है? Grunting is a typical sound that is producing during respiration, and that shows difficulty in respiration. Chest pain may or may not be present. Obviously, smaller children cannot tell about the chest pain. Tachypnea, अभी हम करेंगे कि what is tachypnea? Tachypnea is increased respiratory rate, and someone previously said very rightly, it is dependent upon the age dependent factor. The respiratory rate would be different for a 1-month-old to be labeled as tachypnea, and would be different for a 5 years old to be labeled as tachypnea. Retraction. What is retractions? Retractions are the inward movement of the skin of the chest with each respirations. Like it can be in the form of suprasternal retractions. Suprasternal is just above the sternum. It can be intercostal, like between the two ribs. It can be subcostal, like below the subcostal margin. Signs of consolidation, ये हम कैसे देखेंगे? Obviously through auscultation. Then you can hear crackles, you can hear wheezing, and sometimes the infection is so severe that the smaller children, they do present with cyanosis. Cyanosis is turning blue due to decreased oxygen content. Then sometimes abdominal pain can be one of the presenting complaint of pneumonia, especially in lower lobe pneumonias. Lower lobe pneumonias, it can cause a problem in the diaphragm, and the patient may present with, because of the same nerve supply, the patient may present with abdominal pain. Achha, this is the WHO criteria to label as tachypnea. If you have done IMNCI, so you must have seen it there as well. Under 2 months, 60 is the cutoff. Any respiratory rate below 60 in a child who's not achieved the age of 2 months is considered as normal breathing. 60 or more is defined as tachypnea in a newborn. So if a mother has brought a one month old child and is with the complaint of fever, you have calculated the respiratory rate and it's like 50. So it will not be dropping of shoulder is because of the involvement of diaphragm, and we know whenever there is involvement of diaphragm, the child will voluntarily hold the breath. So coming back to the age-related tachypnea, under 2 months, less than 60 is considered as normal. 60 or more is considered as tachypnea. For 2 months up to 12 months, 50 is the cutoff. Anything under 50 would be considered as normal, above 2 months and up to 1 year. And this is not exclamatory mark, this is 1 to 5 years. So 40 is the cutoff for 1 to 5 years. Adult में क्या है कौन बताएगा मुझे? So is this 40 if it is taking we are taking it normal in under 5 years of age? So अगर if an adult or an adolescent is coming, so what would be the high rate? 12 to 18. This is the normal now. 16 is the normal. More than 20, greater than 25 for adults. I guess it's greater than 30, but I'm not sure. Have not seen adult patients for a prolonged period of time, so I'm not sure. I guess it's 30. So go back and ask some of your adult physicians. I think it's 30 for adults, but usual is 16 to 20 is considered as normal in adults. So see, the definition of tachypnea depends upon the age. So difference respiratory rate can be normal, like this 40 can be normal for under 2 months of age, but this 40 is considered as abnormal for a 5 years of age. Clear है सबको? This is very important slide. Can be asked in your exams or in your MCQs, and we do ask it in your ward test. And this is the basic slide on which you assess the patients. So, like this is a study that is showing the comparative methods for detection of pneumonia in children. So usually in adults, we rely more on auscultatory findings, but since smaller children, they have a smaller chest, they don't cooperate with the examiner more, they are not very much compliant with your commands, so they have checked the reliance of the findings through auscultatory findings and simple clinical findings. So उसमें हमने देखा कि if we use a stethoscope for crepitations, the sensitivity is only 53%, whereas simple clinical signs like fast breathing or chest indwelling, sensitivity is 77%. So it's way higher as compared to the reliance on stethoscope, because there is a possibility that the child is crying at the time of auscultation and you may not be able to hear crepitations. This is the very reason, if you see the charts of WHO in which they classify pneumonia, there is no use of stethoscope in that. They have made the whole classification just by relying on the simple clinical signs like the presence of cough, presence of fast breathing. Fast breathing is obviously tachypnea, and the presence of chest indwelling. And they classify pneumonia merely on the basis of these simple clinical signs rather than using the stethoscope. But that does not mean that हमारी clinical findings have no value. This is just a rough method to do that. अच्छा, ये तो हो गया, हमने clinical examinations कर लिया कि the child may present with wheezing. The most important finding in labeling as pneumonia is fast breathing as well as retractions. ठीक है? So अब the labs have a supportive role. What labs would we do? क्या करेंगे labs में? Which labs would we advise? कौन बताएगा? CBC, ठीक है. What would you see in the CBC? CBC में क्या बताएगा? Consultant की तरह मत बताएगा रो बच्चों. CBC में बहुत सारी चीजें होती हैं. What would you look for in CBC? Hemoglobin पे क्या असर होगा? Leukocytosis. Okay, for every case, is it necessary? अच्छा, what happens in coronavirus CBC? What happens in viral CBCs? चलो कोरोना वायरस नहीं करते, viral CBCs में क्या होता है? If the patient is suffering from viral infection, lymphocytosis nahi hota. Leukocytosis, usually what happens, leukocytosis is in WBC count increase in mostly bacterial causes. ठीक है, leukopenias मिल रहे होते हैं usually हमें viral induced में. So yes, neutrophilic leukocytosis in bacterial etiology, very good. किसने जवाब दिया है? ये मिन्हा ने. ठीक है, न्यूट्रोफिलिक ल्यूकोसाइटोसिस इन बैक्टीरियल इटियोलॉजी. वायरल में यू कैन फाइंड लिम्फोसाइटोसिस और समटाइम्स ल्यूकोपीनिया आपको मिल सकता है. ठीक है, अदर देन दैट सीबीसी में आपको कुछ भी नहीं मिलेगा. व्हाट एल्स वुड यू डू? ESR, somebody said ESR. Okay, ESR is a non-specific finding, it can be increased. What else? Cavitation. अभी हम, हाँ ठीक है, cavitation in the X-ray. X-ray involvement is not necessary cavitation. We can find lobar pattern of lobar pneumonia. We can find interstitial pneumonitis. We can find cavitation. We can even find some complications of the pneumonia. वो क्या होती हैं? Pneumatoceles मिल सकती हैं. We can find pleural effusion. ठीक है, और क्या मिल सकता है? Bronchopneumonia pattern मिल सकता है. और इन्फेक्शन के लिए और क्या करवाएंगे? ESR कैन बी रेज्ड, सी रिएक्टिव प्रोटीन कैन बी रेज्ड. चलो अब इसमें स्लाइड में देख लेते हैं कि स्लाइड में क्या है. WBC count, blood cultures, C-reactive proteins, chest radiographs, bacterial antigen assays, and nasopharyngeal cultures. Obviously, these nasopharyngeal cultures usually that are done in all the viral causes. ठीक है, PCR by the nasopharyngeal cultures. Bacterial antigens. Oh, I think I accidentally stopped sharing. चलो, ABGs. ठीक है, वेरी गुड. ABGs आप कब करेंगे? ABGs आपको यूजुअली डायग्नोज नहीं करेगा बेटा pneumonia. ABGs will tell you about the impending respiratory failure as a complication of pneumonia. Not every pneumonia causes alteration in ABGs. It's only those complicated form of pneumonias जिसमें the patient may need artificial or mechanical ventilation. उसमें ABGs will be deteriorated, but they are not the first line of investigation. तो अभी आपने history ले ली, you examine the child and you will see the WBC count, you will order blood cultures, but the yield of blood cultures is only 30%. ठीक है, like those patients who are suffering from pneumonia, only 30% will have growth in blood CS and 70% will not have any growth in the blood CS. CRP can be increased, and it's more increased in bacterial pneumonias rather than in viral pneumonias. Mostly will rely on chest radiographs and nasopharyngeal cultures for viral causes. Acha, etiological source and clinical grounds. Again, not very helpful, but at least initially, in the initial course of an illness, you can just have a rough idea whether this one is viral one or this is the bacterial one. Sometimes this is not 100% sure, as there is sometimes overlapping of the findings. So this way, this one on the right side of your screen is viral pneumonias, and this one is the bacterial pneumonia. Usually the children suffering from bacterial pneumonia, they are sick looking, and infants and young children, first thing, usually the infants and young children are mostly they have viral pneumonias, and in that they predominantly present with wheeze. Wheeze का cause हमने अभी discuss कर लिया था कि because of their smaller airways and because of mechanical obstruction in their airways, they predominantly present with wheezing. Fever, if present, usually it's not very high grade, but due to airway obstruction, they present with recessions. And X-ray पे आपको hyperinflation मिल सकती है, compensatory hyperinflation मिल सकती है. And due to that obstruction, you can find patchy collapse in half of cases. Usually lobar collapse whenever they are severe. On the contrary, जो bacterial pneumonia के बच्चे होते हैं, they are usually sick looking, they have a fever of high grade, chest recessions तो दोनों में ही होती हैं. Usually primary bacterial infection में wheeze is not a sign of primary bacterial pneumonia, but किन केसेस में प्रेजेंस हो सकती है 20? व्हेन देयर इज सुपर इन्फेक्शन ऑफ अ बैक्टीरियल कॉज ओवर अ वायरल कॉज. ठीक है, as sometimes they both can coexist. So usually what happens in bacterial, usually consolidation ज़्यादा मिलेगी हमें rather than the collapse. ठीक है, whereas in viral pneumonias more findings of collapse. और दूसरा hyperinflation is typically more prominent in those. Hyperinflation हमें chest x-ray में कैसे पता चलेगी? The chest lung piece would be more black. There would be more air trapping in it. That is most likely the finding of viral pneumonias. So there are two x-rays. This one is most likely, you can see hyperinflation. It can be due to viral, and this one, widespread involvement of the both lungs, can be due to bacterial. Why hyperinflation? Beta hyperinflation इसलिए होती है कि there would be air trapping. Like suppose one of the one segment of the lung has been obstructed. ठीक है, the lumens are narrower. ठीक है, the bronchioles are narrower. तो usually air inward to pass हो जाएगी, but when the patient expires, they collapse. The bronchioles collapse. So it would be difficult for the air. यही तो बता रही हूँ, सुन लो ना. Why respiratory rate can be why collapse is seen more in the viral, इसीलिए कि because of mechanical obstruction. ठीक है, usually the air gets trapped. ठीक है, the air that gets trapped beyond an obstructed, mechanically obstructed bronchiole, तो ultimately वो जो air है that would get absorbed and that portion of the lung can collapse. चलो next. We have discussed this thing. The definitive diagnosis of a viral infection rests on the isolation of virus or detection of the viral genome or antigen in respiratory tract secretion. Like until unless you go for a PCR, ऐसे ही आप X-ray देख के you can have an idea, but definitive diagnosis obviously is based on PCR. Again, usually the bacterial pneumonias होते हैं, they are more complicated. They get more complicated easily. Sometimes they causes pleural effusion, so we can isolate an organism sometimes from the blood, sometimes from the fluid, or sometimes directly from the lungs. Bronchoalveolar secretions को हम aspirate करके भी उसके cultures कर सकते हैं. So yes, PCR or cultures, they give us the definitive diagnosis. बाकी सारी चीजों से we just can have a rough idea but not the definitive one. जो भी सारा हमने किया है, जो चार्ट किया था, that will give you some idea. अच्छा, we have already done it. कि peripheral white blood cells count can be useful sometimes in differentiating viral from bacterial pneumonias. ठीक है ना, usually in viral it can be normal or slightly elevated, but usually if it's bacterial cause, so it can be as high as up to sometimes 30 to 40,000 with predominance of न्यूट्रोफिल्स. अच्छा जी, ट्रीटमेंट कैसे करेंगे? तो ये कौन बताएगा? कितनी स्लाइड्स रह गई हैं? देयर आर सो मेनी स्लाइड्स लेफ्ट. हाउ वुड वी ट्रीट? ऑब्वियसली वी विल नॉट वेट फॉर द कल्चर्स. ठीक है, जो अभी हमने सारा क्लिनिकल एग्जामिनेशन किया है, जो एक्सरे फाइंडिंग्स चेक की हैं, तो ऑन द बेसिस ऑफ दैट, ऑन द बेसिस ऑफ हिस्ट्री, ऑन द बेसिस ऑफ ससेप्टेबिलिटी, ऑन द बेसिस ऑफ एज ऑफ द पेशेंट, जो हमने शुरू में एज रिलेटेड इटियोलॉजिकल एजेंट्स किए थे, वी हैव टू स्टार्ट ट्रीटिंग द पेशेंट बिफोर द रिजल्ट्स कम. पीसीआर तो चलो आ जाता है 6 to 8 आवर्स में, बट द कल्चर टेक्स अ लॉट ऑफ टाइम टू गेट रिपोर्टेड. तो उस वक्त तक वी विल नॉट सिट ओनली. yes, we'll start empiric antibiotic treatment. तो उसके लिए you should know कि which antibiotic is targets which organisms. Only then you would start antibiotic based on the age group and based on the susceptible organisms. तो करते क्या है? Empirical treatment suspected bacterial pneumonia in hospitalized child. अच्छा, the smaller the child, the more chances that the infection will spread. तो if we are admitting a newborn, so we'll cover, हमने उसका etiological agent किया था ना कि they are both gram positive and gram negative, तो obviously we'll have to give the coverage of both gram positive and gram negative organisms. उसमें आप फिर usually start with ampicillin and gentamicin, ampicillin from gram positive and gentamicin from gram negative for a newborn or extended newborn sensitive antibiotic test. ठीक है, and we'll wait for the cultures to be reported. third generation cephalosporin is usually the mainstay in beyond the neonatal age. It can be cefotaxime, it can be ceftriaxone. If we are suspecting any bacterial pneumonia, so we empirically start with the third generation cephalosporin, cefotaxime and ceftriaxone. You don't have to remember the dosage because it's beyond your level. If the clinical features such as staph pneumonia, like pneumatoceles or empyema is there, so we have to include, is हमें पता है कि staphylococcal अगर if it's methicillin resistant, so we have to give, depending upon the clinical condition and the X-ray findings, we can add vancomycin or clindamycin to tackle this staphylococcal pneumonia. ठीक है, उसमें सिर्फ ceftriaxone does not have a very good coverage for staph pneumonias. If isolated viral pneumonias, no need of antibiotic therapy. But for that, you have to be very confident about your findings. Like, it's very difficult to differentiate clinically between a viral pneumonias and a bacterial pneumonia. So since viral PCRs is not widespread available everywhere, so what is the usual practice? Viral पे antibiotics तो कुछ करेंगे नहीं ना, we all know that. But despite, you must have seen so many of the physicians prescribing antibiotics even for the viral pneumonia. The reason is that until unless you get a confirmatory test, you cannot say if it's viral. Second, sometimes the findings are overlapping. Both of them are present to give the benefit of doubt to the patient. Sometimes it is needed to start antibiotic even if you are suspecting the predominant viral one. For all the viral pneumonias, only supportive measurement is required. Supportive treatment. Supportive treatment क्या होती है? Like if the patient is being tachypneic, oxygen therapy, increased fluid intake. ठीक है? If fever is present, treat the fever. Supplemental oxygen therapy. These are the supportive findings. Okay, good balance of fluid, increase good and balanced caloric diet. These are all considered as supportive therapy. And sometimes if wheezing is present, so we have to give nebulizations of short-acting beta agonists. So these are basically the risk factors for pneumonias. Viral infection, will we stop antibiotics? Yes, if the PCR for any of the virus has came positive, so we will stop antibiotic. Or sometimes, depending upon the condition of the child, we can continue it for 5 days. So there was in a study, it was found out that the mortality was associated. The close associators were those children who were breastfeeding. They have decreased mortalities. Education of the father is obviously very important. It tells you, it decides the behavior towards the illness. Number of under 5s is again important. क्यों important है? Because if there are more children under 5 years of age, the mother will not have the time to take care of the ill child. Family income and birth weight. Obviously, with decreased birth weight, the immunity is decreased, and there are so many other problems with decreased birth weight. So they all are related for add up to the mortality and morbidity of the child. अच्छा, प्रिवेंशन कैसे करेंगे? हाउ विल वी प्रिवेंट निमोनिया? ट्रीटमेंट तो हमने कर लिया. हाउ विल वी प्रिवेंट? What can be done to prevent different types of pneumonias? कौन बताएगा? जल्दी बता दो. We just have last 10 minutes. How to prevent pneumonia? Treat तो कर लिया. How to prevent? Is there anything that can be done to prevent pneumonia? Vaccination for H influenza. कौन सी वैक्सीन होती है H influenza के लिए? Which vaccination schedule do we follow here? Breastfeeding. Okay, early initiation of the breastfeeding prevents the child from getting pneumonias in infantile age. HIP vaccine, EPI vaccine. EPI का schedule कौन बताएगा? जल्दी से बता दो, EPI में कौन कौन सी वैक्सीन ऐसी हैं जो कि प्रिवेंट करती हैं निमोनिया को? HIP वैक्सीन अकेले तो नहीं देते, कैसे देते हैं बेटा? Who will tell me? How do we get PCV pneumococcal vaccine? ठीक है. Is it given individually or with some other things? How many vaccines in EPI? देखो, we follow in Pakistan the EPI schedule. Now, who will tell me which vaccines are given in EPI that help prevent pneumonia? जल्दी बताओ. You just have 5 minutes. ये मैं this I will not 9 क्या? 9 vaccines. अच्छा, total 9 vaccine. Which vaccine among the EPI vaccines will prevent a patient from pneumonia? Hurry up. This is your homework for today. There are 300 students. All of them are sleeping or what? No one from the 300 strength know about the vaccine that prevents pneumonia in EPI? H influenza, pneumococcal कब देते हैं बेटा? कौन सी किस वीक पे देते हैं pneumococcal? When do we give pneumococcal vaccine? 6 weeks. ठीक है, तो बेसिकली देर आर pneumococcal PCV14. ठीक है, जाग गए सब लोग एंड टाइम पे. Okay, so we have 2 vaccines which prevent us from pneumonia. One is देखो HIP जो है ना isolated नहीं देते. We give it either in the form of pentavalent or in the form of hexa, Infrarex hexa or hexavalent. ठीक है, अब penta has, as the name itself explains, it has 5 components. The previously given DPT, diphtheria, pertussis, and tetanus. So, well, diphtheria is again one of the cause of causing lung infection. But since DPT was in use for a prolonged period of time, so diphtheria incidence of involvement of the chest has been decreased. But since TPT तो हो गया, उसके साथ हम Hep B देते हैं और Haemophilus influenza type B. तो Hep की vaccine is the part of pentavalent vaccine that is given in Pakistan at 6 weeks, at 10 weeks, and 14 weeks. Then later on a booster at 12 to 18 months, and then another booster at 4 to 6 years of age. And along with that, now the government of Pakistan has also included pneumococcal vaccine as well in our vaccination schedule. वो भी हम along with penta दे रहे होते हैं. Pneumococcal vaccine is given along with penta at 6, 10, and 14 weeks. ठीक है, तो these 2 vaccines protect us, our babies, from getting these pneumonias. But still इसमें अभी और फिर after 6 months एक और vaccine हम देते हैं. Annual influenza vaccine can also be given after 6 months of age. So that will prevent again influenza virus. But again ये लगाने के बाद भी बहुत सारे बच गए. Streptococcus A बच गया और कौन सा बच गया? Staph aureus हमारा normal commensal है, that is left. And there are other so many viruses like respiratory RSV, respiratory syncytial virus होता है, adenovirus है. There are so many other viruses जिसकी अभी तक there are no vaccines. तो उनके लिए क्या करेंगे कि जिनकी vaccines नहीं है? ये तो vaccine preventable हो गया. Other than that, what else can be done? Good hygiene. Somebody said breastfeeding. So, good hygiene, breastfeeding, avoidance of overcrowding, good nutritional status. क्योंकि देखो, Staph aureus is one of the commensal. So, if internal body defense mechanism is stronger enough, the outer bacteria cannot infect. So, I think we are coming to the end. Chalo, US ke data. Achha, there is another thing. Studies have shown that vitamin A supplementation also reduces the mortality and severity of the respiratory infections in children with measles. So, vitamin A has a role in regeneration of the epithelium. So, agar measles pneumonia hai, तो obviously vitamin A can help. Again, zinc also has some effect in pneumonia. So along with that, zinc again has, as we all know, zinc has role in regeneration of the epithelium. तो जहाँ जहाँ epithelium involved है, जहाँ जहाँ epithelium destroy हो रहा है, be that be in diarrhea, जैसे हम diarrhea में well established role है zinc का, there are so many studies which are favoring the good effects of zinc even in pneumonia as well. So the same supplementation of zinc in pneumonia as well. And again, all the fat soluble vitamins, because we have to take it. Good nutrition, stop smoking, because passive smokers, children, although they are not the active smokers, but they are very frequently the passive smokers. So it again, it will decrease the immunity of the child. And improvement of the pollution, improvement of the environmental concentration, good internal defensive mechanisms, and improving educational level, and with good hygiene and hand hygiene, we can prevent pneumonia. So with this, we come to the end of the slide. You can ask questions if you people want. We just have 5 minutes left. Any questions? खत्म हो गया क्या? लेक्चर हो गया?
नहीं मैम, चल रहा है, वो क्वेश्चन वगैरह हो गए तो मीटिंग एंड कर दें.
नहीं, मीटिंग एंड में भी चल रहा है. एनीवन हैज एनी क्वेश्चन? हाँ, चैट खोल दीजिए. स्लाइड शेयर एंड हुआ है, मेरे ख्याल में वो नहीं हुआ.
स्लाइड तो आपने मैम रिमूव की ना.
हाँ, स्लाइड एंड हो गए वो. आई थिंक तो चलो, आई थिंक देयर इज नो क्वेश्चन. कैन टीबी एंड ब्रोंकोपल्मोनिया बी डिफरेंशिएटेड ऑन चेस्ट एक्सरे? अच्छा, वॉइस खोल लो, खुली तो हुई है ना. To some extent, we can differentiate tuberculosis and bronchopneumonia, but not definite. It's not the definite thing. Why sputum is introduced in children? So, bhai, Shazeen cannot tell you now. I think you have joined late. Can a newborn produce sputum due to certain infection? No, newborn cannot produce sputum. All the things would be there, the inflammatory mechanisms would be there, but they cannot spit out. Okay, they will have a wet cough, but they are not able to produce sputum. Anyone else? Any other question? Is there, if there is only cough with sputum, then what is the treatment in adults? Beta, this cough with sputum can be community acquired pneumonia, ना उसमें fever नहीं होता है. तो if it's viral, और आज के हालात में देखें तो go and check for COVID. What is retraction? Retraction is the inward movement of chest with breathing. ये मैंने शुरू में बताया था. It can be supraesternal, it can be intercostal, it can be subcostal. Neonatal respiratory distress syndrome. Why does administering oxygen induce retinopathy? अच्छा, इंटरवेंट्रिकुलर हेमरेज एंड ब्रोंकोपल्मोनरी डिस्प्लेसिया. किसी ने ये सवाल पूछा है. इट्स अ वेरी गुड क्वेश्चन राफे, बट चलो देखो, RDS usually is an illness of newborn, the premature babies. So what happens? Premature babies, their brain, their lungs, and their eyes. So if we give persistently high levels of oxygen, like we give it in through artificial ventilation, उसमें हम we start with the हमारे normal air में कितनी होती है? 21% oxygen होती है. And when we give it, we start off with the 100% oxygen, but we have to wean it down as soon as possible. नहीं होता तो ऑक्सीजन टॉक्सिसिटी हो जाती है. एंड ब्रोंकोपल्मोनरी डिस्प्लेसिया इज नॉट ड्यू टू ऑक्सीजन थेरेपी. ठीक है, ऑक्सीजन इंड्यूस रेटिनोपैथी तो ड्यू टू परसिस्टेंट हाई ऑक्सीजन की वजह से होती है. बट बीपीडी इज नॉट ड्यू टू डेथ. इट इज ड्यू टू immature lungs that suffered with any illness, and it is the term that is given to those children who had persistent requirement for oxygen after 28 days of life. तो इससे ज़्यादा भी नहीं बता सकते वो. I don't know whether you are from DMC or DIMC. तो when you will go back to your clinics, you can discuss it with your teachers. अगर हमारे पास DIMC में आओगे तो you can come to us and we'll discuss with us. अच्छा, which type of pneumonia is most common in peds? Go back to second and third slides and you will know which type of pneumonia is more common. But yes, in smaller children, toddlers, it's viral pneumonia. Okay, Rafit, so that you can come whenever you join. You can come to, you'll obviously come to a wards to us. So यहाँ पर तो different wards है ही नहीं, तो obviously you'll come to us for your clinical posting. So here we will discuss this in detail. Any other question? So I think there are no questions. Okay, so shall I end? Thank you so very much for listening.